Um, Today we're going to be talking about pediatric femoral shaft fractures. Generally, when I do a presentation, whether it's for a rotation or for this here, I'll practice beforehand and I'll watch it back. So it's generally why I like to practice beforehand, just kind of get an idea of how I sound. But today we're talking about pediatric femoral shaft fractures. We'll first go into a little bit of the epidemiology. They're about 1.6 to 2% of all pediatric fractures. It is the most common reason for pediatric hospitalization due to an orthopedic injury. Occur mostly in males, and there's a bimodal distribution from about 2 to 4 years, and then again in mid-adolescence. Talk a little bit about the anatomy. Obviously, the femur is the largest tubular bone. It's got a large surrounding muscular mass with lots of deforming forces, and the femur has an anterior bow. I like this image here on the right. It has kind of the deforming forces on the different parts of the femur. So A here kind of shows the flexion and adduction kind of force that's provided by the abductors. B here is the attachment of the iliopsoas, is going to provide a flexion force. The C here, adductor canal, is going to provide an adduction force, right? So a varus force. E is the attachment of the gastroc. E is the IT band, is going to kind of pull the proximal segment. In terms of mechanisms for peds femoral shaft fractures, less than 10 years old, most common mechanism is going to be from a fall. Greater than 10 years old, the mechanism is usually due to trauma, like an MVA or high-impact sports. Also want to consider pathological causes of these fractures, like OI, osteopenia secondary to some neuromuscular disease, or tumors, of course, but not malignant. Something to note, and I'm not going to get into the whole thing here, but you want to have a high suspicion for abuse in children less than 3 years old, or if they're not old enough to walk yet, and they come in with these kinds of fractures. And just to note, a transverse fracture is more common in non-accidental trauma. Moving on here, in terms of clinical evaluation, when you go see this patient, the ED, you want to take a look. You want to get a good neurovascular exam, right? Are they neurovascularly intact? Do they have pain, tenderness, swelling? They probably will have the inability to bear weight. You'll probably see a gross deformity on exam. You want to examine the hip and the knee as well for associated injuries. And you also want to look at for Waddell's triad in a polytrauma, which is a femoral shaft fracture, a same-sided intra-abdominal injury, and a contralateral head injury. So Waddell's triad is commonly seen in polytraumas. You want to assess for that, especially in a young patient. Now, in terms of radiographic analysis, pretty simple. Get an AP and lateral of the femur. You also want to get dedicated films of the joint above and below, so the hip and the knee. Now, in terms of acceptable radiographic tolerances, this is a figure right out of the Handbook of Fractures here. And children generally can tolerate pretty high tolerances of deformity. So generally 2 to 11 years old can tolerate up to 2 centimeters of shortening. Greater than 11 is a centimeter of shortening. And in terms of angulation, it's going to be age dependent. So angulation decreases as age increases. That is, your tolerance for angulation decreases as the age increases. You can kind of see how that goes in this chart right here. As you're increasing in age, your angulation tolerances decrease. And you can tolerate about 10 degrees of rotation. External rotation is tolerated better than internal rotation as well. Moving on here in terms of classification, these have a descriptive classification. So what kind of fracture is it, right? Is it open or closed? Is it of the proximal, middle, or distal 1/3 femur? Is it transverse, oblique, spiral, or comminuted? Now, an important note to make about these fractures is stability. And in terms of peds femoral shaft fractures, we talk about length stability. So a length stable fracture is either a transverse or short oblique fracture, and a length unstable fracture is a comminuted fracture or a long spiral or long oblique fracture. Now, what defines a long versus a short? A long fracture is one where the fracture length is 2 times the bone diameter at that level. That's what makes it a long fracture, and those are unstable. And we have images here on the right of a stable fracture, just a simple transverse, versus a long oblique fracture here. This is an unstable fracture. So moving on. In terms of treatment options, historically these were treated with spica casting, with or without traction, although there has been a trend over the past 20 years towards more operative treatment, and operative indications depend largely on age and weight, as well as stability of the fracture. So non-op treatment for these patients, any peds femoral shaft fracture that comes in and they're less than 6 months old, they're going to get a Pavlik harness. We see this here. We've seen this, if you're familiar with the treatment of DDH, you're familiar with this Pavlik harness here. So anyone less than 6 months old gets a Pavlik harness. From 6 months to 5 years, they're going to get a spike cast here. And if, it's rarely done anymore, but in cases of severe shortening, you could do traction plus delayed spike casting. In terms of operative treatment, you basically have 4 options. You can do a flexible intramedullary nail, you can do submuscular bridge plating, antegrade rigid nail, or an X-fix. So in terms of flexible IM nail indications, they're going to be used in length stable fractures in 5 to 11 years old in patients that are less than 49 kilograms or 100 pounds. For submuscular bridge plate fixation, they're going to be used in length unstable fractures in patients greater than 5 and greater than 49 kgs, as well as a comminuted or a very proximal or distal femur fracture. In terms of antegrade rigid nailing, they're going to be used in patients greater than 11 years old, greater than 49 kgs, especially in length unstable fractures. And then in terms of an X-fix, you could really use it as a definitive treatment, but it's more often used in polytraumas and open fractures. But it is a definitive treatment for this fracture. And here I just wanted to give an example of what these kind of look like. So here on the left, you got your submuscular bridge plate fixation with 3 screws, about 3 screws below the fracture, spanning the fracture site. B here are your flexible IM nails. It's actually 2 nails, one inserted medially, one laterally, and you want to make sure that the combination of the width of the nails comprises 80% of the femoral canal. That's an important note. And in terms of this antegrade rigid nail, an important note is that you want to have a more lateral starting point. You don't want a piriformis start and you don't want a trochanteric start, as those are more highly associated with AVN. So you want to have a lateral starting point if you're doing a rigid antegrade nail in these patients. And here's just a picture of an X-fix, again, more used in trauma, but definitive treatment. So in terms of treatment algorithm, this is the one from Ortho Bullets. This was from a paper. I thought it was entirely egregious, that treatment algorithm. But here's one I found, this paper. I believe this was the Indian Journal of Orthopedics in 2021. It kind of outlines your algorithm here, and it basically, again, shows you based on age. Less than 6 months, you're going to get a Pavlik harness. From 6 months to 6 years, and again, your years kind of vary. I previously said 6 months to 5 years. This says 6 months to 6 years, whatever you want to call it, right? You can get your spica casting. Now, from 6 years to 12 years, that's when you're going to use, okay, is it unstable or stable? Okay, if it's stable, if they're less than 49 kgs, get a flexi nail. Greater than 49 kgs, you can get a submuscular bridge plate fixation or flexible nailing. Now, if it's unstable, you can go to plate fixation or external fixation. Now, if you're greater than 12 or greater than 11, as I previously mentioned, you're really going to go with your rigid nail in these cases. So something I just wanted to briefly mention is this was a paper. This was published in Journal of Pediatric Ortho in 2020. It is a systematic review and meta-analysis of 5 studies, included about 500 patients ages 4 to 16 years old, and they analyzed the outcomes and complications of flexible nailing in heavier kids, which they defined as greater than 40 kgs. Now remember, most of the tolerances here are at 49 kgs, your cutoff. So this paper looked at 40 kgs as heavier children. So they found that flexible nailing in children over 40 kgs had higher radiographic non-union and malunion, higher overall complication rates, and a 23% reoperation rate for refracture in heavier children. Now, this is important because the AOS acknowledged that flexible nailing in patients greater than 49 kgs have poor outcomes, but again, this study suggests a tolerance of 49 kgs might be too heavy. Some of the literature also mentions using stronger flexible nails like stainless steel versus titanium, but there's no formal studies comparing the outcome of stronger nails being the stainless steel to more flexible titanium nails. So this is just some food for thought. Different people do different things, and this is kind of a study that might lead you to perhaps a bridge plate or a rigid nail in a heavier patient. In terms of patients of these patients, your biggest one is going to be leg length discrepancy, and actually what you're going to see more often is overgrowth. You can expect 0.7 to 2 centimeters of overgrowth in children less than 10 years old, which is why they have a high tolerance up to 2 centimeters of shortening, because that limb will overgrow. Additionally, AVN of the femoral head, especially if you're using a rigid antegrade nail. Also non-union, malunion, as well as fracture. That I have today. There's my references. And that's Pete's femoral shaft. Thanks.